Evening, everyone. Welcome. This is AONM's webinar on the convergence of two pandemics, Lyme disease and COVID-19. We're delighted to have Professor Bransfield with us here this evening. Unfortunately, due to unforeseen circumstances, Dr. 𝐸𝐵𝐺𝐸 can't join us today, but he has specifically requested to reschedule, and Professor Bransfield has agreed to join him again. So hopefully that'll be very soon, and we'll let you know. So I'm sure all of you know Professor Robert Bransfield. He's a board-certified psychiatrist. He's a clinical associate professor at Rutgers Robert Wood Johnson Medical School, and also works in private practice. He's held teaching appointments at Hahnemann Medical College, Eastern Virginia Medical School, and he has a particular interest in psychopharmacology, a unified theory of mental health and illness, and the link between microbes and mental illness, Lyme and other tick-borne disease, and the link between microbes and violence. So we'll be having a discussion this evening based on questions that we've already received in advance, as well as questions that you're very welcome to put into the Q&A or the chat, and we'll be covering as many as we can. So thank you very much, Professor Bransfield. Maybe you'd just like to say a few words of introduction first before we get going.
Okay, well, I'm happy to be here. We've had a number of these conferences, and I've been there in person in the past, and I think this is a very enthusiastic group, and it seems like we're coming out of the back end of this pandemic some, and it's a question that comes up a lot of Lyme and pandemic, how they interact, and we can touch on different parts of that. And I'm not sure we want to start with, I was thinking one basic area is when you have Lyme and then you get COVID, what happens? Another question is, what does this tell us about our healthcare system? And, how has this whole experience with the pandemic impacted the way we view conditions like Lyme and other complex illnesses? So I think those are three general areas, and maybe also, since we have an audience, like what's new, what's on the horizon, what's happening now, we can address that too. Okay.
Yes.
So I'm not sure where you want to start.
Several of the questions came through asking, does the Borrelia bacteria become active again after COVID-19 infection? Have you found that yourself over the last 3 years?
I've found that to be true with some people, and it's always. And when I gave my original talk, and I think it was there, I had a hypothesis that I was seeing three patterns. And one pattern was that people that were under treatment for Lyme and then got COVID generally kind of did okay, because a lot of the treatments for Lyme overlap with the treatments for COVID. So they were somewhat kind of had prophylactic treatment in a sense. And the other, looks like Dr. 𝐸𝐵𝐺𝐸𝐿 joining us here. Okay?
Yeah, wouldn't that be wonderful?
Okay, that's good. And then the other part was people that weren't under treatment, I found a fair number of them relapsed. And they often showed, even though the symptoms for Lyme and COVID overlapped, you could see some of the symptoms more specific to Lyme emerge, Bell's palsy and things like that. And then I think the third thing I saw that was a smaller group, and I really just saw it in the beginning of the pandemic, was there was a couple people that had very high fevers. And some of those people, I think, benefited from the high fever like it was almost therapeutic. But that was only a few people, and I'm not seeing the high fevers now. And I think defining what the overlap is like a moving target, because COVID kept changing. In the early part of the pandemic, it was a lot more lethal and dangerous. And as it's progressed now, it's a milder condition. So I don't see so much the severe acute symptoms like I was saying, And likewise, I don't see so much of the chronic symptoms that are the fallout from it that I saw with people that were infected earlier in the epidemic.
Right.
So it's, and if you look at these studies, a recently done study can say, well, there isn't much of a residual, but that was a study that was just done recently. Whereas if you look at the studies done a while ago, there was a lot more of the residual. And, you know, and it's, so I think what happens is that COVID has some immunosuppressant effect.
Okay.
And you see activation of whatever the person may be prone to, be it Lyme or otherwise, becomes more active. And it's, I think that just doesn't, it's just not Lyme, it may be other things.
Yes,
And
I mean,
maybe that's why sometimes some of these people particularly benefited from the ivermectin, that may have approached the spectrum of some of these co-infections.
yes, the second half of that question that I began with was, if so, how to recover? But of course, that's a very difficult question to answer, isn't it? Because it so much depends on the part of the organism that has been affected by COVID, presumably, and what you know, pre-morbidities the patient had, and so on. So that's very difficult, isn't it? Whether to go in pharmaceuticals or natural remedies, or both.
Well, I think the trick there is, you know, when you look at like people are algorithm driven, like these computer algorithms, and these big healthcare systems have these algorithms, and some doctors are handcuffed to follow these algorithms, like using remdesivir when it's dangerous for kidneys instead of using ivermectin. That's much safer. And but the hospitals financially benefited more with remdesivir. So I think if you look at treatment strategies, the big thing is treatment always has to be individualized. It just can't be an assembly line and same for everybody.
Yeah.
When we have a research study, we treat aggregate data. We don't, and aggregate data may show a statistical correlation, but you're not an aggregate data. You're an individual, and you have to do, there's no treatment that works 100% for everybody. So you can never go by these studies and say it must apply. You always have to individualize it for everything. I think that's the number one thing in any treatment strategy. It must always be individualized. And then I think look at treatment in four basic ways. And I think whether we're talking Lyme, COVID, or the mix, or any of these illnesses, it's always the same formula. I think one part can be there may be some chronic infection or some other environmental trigger that needs to be addressed, or there may be multiple infections or environmental triggers. That's one part. The second part is then that gives the immune system and trying to normalize immune functioning so it's adaptive instead of maladaptive.
Yep.
And then the third part can be treating the symptoms, and having runaway symptoms that put someone in stress mode often cause disease progression, figuring out what symptoms do that. And then the fourth part is just general education, whoever's involved in the case, so they understand it and pull it together and look at where's the best way to intervene. Now, if you're an immunologist, your bias may be just to focus on that, or our bias is to focus on what we know. And that may match with what the patient needs, but may not. So we have to kind of work with other people in a collaborative way and go outside our area specialty and look at what works best. It's like a tangled ball of string, and how do you untangle it? Where do you start first, second, third in that process? My average Lyme patient in one study had 82 different symptoms.
Oh.
And that's the average. I've had people with 200. But when you look at that and you say, well, now that you have all those symptoms, what do we do to get you better? Where do we start? And it's a different starting place with different people, with different patients.
Yeah.
And I think that's the art of it, is figuring out where do you start with any given patient and what do you do in what sequence. And you could look at those different areas. Part of education is understanding it, but is it infection or some other trigger? Is it the immune? Is it the symptoms? What's the best part how do you intervene so you get kind of the most bang for your buck, so you get the greatest impact with the minimal risk, the minimal, so it's not too overwhelming or even costly to the patient.
Absolutely.
I think that's the basic logic to do. And it's a complex interactive infection, we're dealing with. It's just like we're dealing with when we think of Lyme with co-infections or opportunistic viral infections or mold. It's the same issue, whether it's COVID or some other thing. I have these, okay?
Yeah.
Just a minute.
Your second question, or the second point you made.
Yeah, somebody's trying to get on this where you are. How does someone get on this if they don't know how to? They go on.
Claire, could you maybe just hop in there?
Okay.
Oh, look, a link has been posted at the bottom. Joan Cass has very kindly posted the link. So
That's in the chat. Okay.
Yes, it's in the chat. It's one of the very most recent links that's been posted.
It's kind of hard. It's hard to copy all that. Okay.
Yeah. Otherwise, there is the invite that we sent out, which had the link in it. And on the AONM page, there's an events tab. And if she goes to events, she'll see that this is
okay. You want to do that?
The event
all right,
for the day.
All right, thanks.
Thank you very
Okay.
much.
All right. Okay. Right.
Yeah. So Professor Bransfield, the second topic that you suggested that you thought would be interesting to discuss is what are the similarities and differences of the public health response to Lyme and COVID? Maybe you could say a few words about that.
Yeah, like one issue is when we have a complicated medical dilemma, like who are the experts? Now, one group of experts are backline bureaucrats that never treat patients. And they could be academic doctors who they read the literature, or epidemiologists or public health officials. And then the other people are frontline doctors. Now, the frontline doctors with Lyme are the people that are treating thousands of Lyme patients decade after decade, or with COVID, it may be the doctors working in intensive care units that are working 12 hours a day in intensive care units. Now, who do you listen to? Do you listen to the frontline doctors, or do you listen to these policymakers, these bureaucrats who are data analysts? Okay. Now, admittedly, in medicine, you want to pay attention to both data and clinical realities. But I think there was a push-pull and there was an excessive weight with these backline bureaucrats and bureaucracies instead of frontline physicians. And that was pretty clear with COVID. There were a lot of these doctors who had a good feel of how to manage these patients early in the disease by clinical experience. But there's a certain academic medicine, maybe we could say snobbery, of that this is anecdotal evidence that's poor quality, and we only go with double-blind controlled trials, which take forever to do.
Yep.
And both have their place. You have to blend, but you can't ignore the frontline doctors. And I think when it's a rapidly changing thing, it's the frontline doctors that figured it out.
Absolutely.
And the frontline doctors that knew what they were doing. And we saw the same with COVID. We saw the same with Lyme. We see the same with chronic fatigue or fibromyalgia, or any of these rapidly emerging things that are hard to figure out. Yeah. Because a lot of these things that are based on controlled trials and data analysis take forever.
Absolutely. Yeah.
So it's the same problem. It's the bureaucrats versus the frontline doctors.
Yeah. Yeah. One of the questions that came in earlier, these are a few more sort of granular questions, is if someone's bitten by a tick or a horsefly, can psychiatric symptoms manifest before any actual physical symptoms?
Sometimes. I think it happens more commonly when it's a whoops, my screen just went funny. Okay. I think it happens more commonly when a person's partially treated, right? So let's say somebody gets Lyme tomorrow. Not everybody gets the bullseye rash, and not everybody who gets it sees it, okay? And there may be that flu, and then maybe the aches and pains, and then usually the psych come later. But if you're partially treated, it may be enough to treat those things, but the psych symptoms may be the first to begin. However, in one study, they looked at early infection, and early infection, the Borrelia penetrated the CNS very early in the disease. So you can get it early in the disease. And I think it can be almost only psych if it's partially treated and inadequately treated.
Okay.
So there's this phrase they came up with the IDSA guidelines of post-treatment Lyme. And really what it is why call it post-treatment if the person was inadequately treated and still has symptoms?
Yeah.
So it's post-inadequately treated, post-inadequately diagnosed,
Absolutely.
post-delayed diagnosis, post-delayed treatment. So it's a bogus term, but I guess from a medical legal standpoint, it's a brilliant way of protecting yourself from making a judgment error of inadequately diagnosing and treating someone when you should have, okay?
Yeah. Yeah.
And maybe that's the purpose of the term,
Yeah.
rather than being medically accurate. Now, we see the same juggling around with nomenclature. With nomenclature, we see the term of, like, with COVID, people have chronic COVID. Why not call it chronic? They have chronic symptoms. Why is there such a fear of calling something chronic when it's chronic?
Yeah.
And you know, they came up with all these weird terms of truck driver terms, of long haul, you know. Why do you have to beat around the bush and call it something it's not? Dr. Jemsek uses Lyme complex, and I think that's good. And that's used in the medical literature, and it shows it's a complex condition. We used to have the same thing in psychiatry, where we had the term psychoneurosis.
Mm-hmm.
And what's psychoneurosis? All right, psychoneurosis, psychosis, and organic brain. Those were the three diagnostic entities. But I think the tick-borne disease working group in the United States came up with the term of chronic Lyme, persistent Lyme. That's the term they used in their final report to Congress. They did not use post-treatment nonsense terms that are bogus. Yeah. They used the valid term, and that was the final government report to Congress. Mm-hmm. So that's the, you know, it's an official government document using that term. Mm-hmm. Instead of beating around the bush. Now, people can argue chronic, or there's post-acute sequelae. Late stage, I think, is a good phrase, because you're not making a judgment, because sometimes you don't know, is there persistent infection or not? And is there persistent infection that's active or latent? You don't know that. So chronic may imply chronic infection. It may or may not be active infection or latent infection, but there's chronic symptoms. Yeah. Yeah. So I think that's a lot of confusion. There's still confusion a lot with Lyme disease.
Yeah,
and what you call
no,
it.
It's the definition of all these terms, isn't it? Another question here, I know it's a very broad one, but maybe you could just comment briefly on it, is, and this is from I think abroad, in the States. I would love it if you can comment on the scientific evidence and link between Lyme borreliosis and any infection, which now includes COVID, and mental illness. Now, that again may well involve definitions that are hard to grasp.
Well, from that
question, isn't it?
All right, from that, actually, I'm working on a journal article called Microbes and Mental Illness. Okay?
Oh, really? Wow.
And I run the Microbes and Mental Illness discussion group for doctors, and I've been doing that for 24 years now. Mm-hmm. And it's 750 doctors on that list. But basically, in the peer-reviewed literature, there are today 493 peer-reviewed journal articles showing a link between Lyme, tick-borne disease, and mental illness of one sort or another.
Right.
And there are 86 peer-reviewed journal articles showing a link between Lyme, tick-borne disease, and dementia. Okay, so together that's almost 600. Okay, and they look at it different ways. Now, there's different evidence. Some is case reports. Some is series, like I've done series. But I think the most compelling, and people like to use the phrase gold standard, and the gold standard really are autopsies. And I recently did, I'm working on a case, and I recently presented in Europe and Germany, and it was an autopsy showing how there was a correlation between Lyme and the psychiatric symptom. And even though this person had what was considered adequate antibiotic treatment, we found Borrelia. We found evidence of the Borrelia activity in the brain, and we found Borrelia in the heart and in the pancreas. And there's other studies like that. And there's actually a very interesting study out of Iraq. And the study out of Iraq showed they took psychiatric patients, and 66% of them were positive in serology to Lyme disease.
Oh, wow.
So there was a study in the Czech Republic that it didn't show that high a number, but it showed certainly a higher number compared to the placebo group. So there really is an awful lot of evidence. Now, in that project I'm doing, the Microbes and Mental Illness Project, I'm not just looking at Lyme disease or tick-borne disease or Borrelia. I'm looking at all infections, and I'm looking at 7 different mental illnesses that we're focusing on particularly. And that includes autism, schizophrenia, bipolar, depression, anxiety, suicide, and aggressive behavior. And there's quite a bit of evidence in all those categories of infectious disease contributors.
Right.
Now, that doesn't mean all autism is caused by infectious disease, and there's about 20 different infections we've identified. But that's one of the triggers that are contributors. And so there's multiple contributors, multiple deterrents with the formula, and you have to use a complicated formula with complex disease. It's not just A equals B and it's simple as that. So it's not like hemophilia where there's a gene and it causes it, and it's rather black and white. It's often much more complex than that. But there are many different, and there's certain infections that keep coming up again and again. So you can see Babesia, Bartonella, you can see certain viruses. West Nile comes up with depression, although we don't see West Nile so much now. And certain parasites too. And human endogenous retroviruses come up, particularly with schizophrenia, toxoplasmosis, parasites. So it's, there's an awful lot of models of that connect infection with mental illness. And mental illness, I think when some people make this mistake that when you can't explain something, then it's mental illness, because mental illness comes from nowhere. It just comes out of a vacuum. That's the way some people think. I don't understand that logic, but it's the way, I hear people process things that way. And psychiatric illness, and that's the part of the movie that we released, is the name of the movie is I'm Not Crazy, I'm Sick. And mental illness has a very clear sequence of what causes it and why symptoms happen in the way they do. It's very logical. You may have some trigger, be it infection or otherwise. Then you have an immune reaction. You have a neurotransmitter reaction. It affects a brain circuit and it causes a symptom. Yeah. And people use the phrase, I'm not crazy. Crazy is what you don't understand.
Yeah, that reminds me of, go ahead, sorry.
Yeah, so I could say our financial system is crazy because I don't understand it, okay? Or political system's crazy, or our healthcare bureaucracies are crazy. But if I understood it and I know the dynamics, I wouldn't call it crazy.
Yeah.
So mental impairments are very logical, explainable, predictable, and treatable if you understand the dynamics that control how they operate.
Yeah. It reminds me of that film called My Kid Is Not Crazy. There have been comments, as you've been speaking, about Susan Swedo, the study on PANS and strep and OPD. Have you seen an increase in what's termed PANDAS, as well as PANS, which also you're a great specialist in, over the last 3 years due to COVID?
Yeah, I see a fair number of those cases, and those are very difficult cases. They're the autoimmune encephalitis cases.
Yeah.
And they go in the hospital and people try to call it schizophrenia. It is not, it is delirium.
Mm-hmm.
They're in a delirious, confusional state. And they, they're all very similar. And you can see questionable seizures with some of these cases. And they may try to jump out of windows. They may take off their clothes. They may try to assault their siblings. They can crawl under furniture. They can be very bizarre. They're in a delirious, confusional state, and it can come and go. And there you think of more like the immune interventions, and it can come on very acutely. I have one, and it's seasonal. He has seasonal allergies, and that triggers it. Yeah. Although some of these are infections, but you don't always know what the trigger is.
Absolutely. An important comment has been put in the chat, which is that the UK has a specific PANS TBI, that'll be tick-borne illness support group, because numbers are increasing. So we've certainly seen numbers increase, particularly over the last year, as strep A has appeared to become endemic among children, especially.
See, I think part of that, whenever there's an increase, your question is there an actual increase, or is it the woodwork effect where it's always been there, and now that we notice it and categorize it and have a name to it, now people are coming out of the woodwork and coming forward, whereas before they suffered in silence? I think some of it is an increase because what's happened is during the pandemic, people were reclusive. So they were reclusive for like 2.5 years or so, hiding under a rock. And when that happened, the colds and the flu and the strep and the RSV, all those numbers dropped. But now that we're getting back into the mainstream of life, we're catching up on all those infections that we didn't get for a couple of years. And then you're seeing probably more of this strep and more of these contagious diseases. And I think that's probably causing an actual increase because of that catching up of these things that we probably lost our immunity to when we were hiding under a rock and isolating ourselves.
Yeah, thank you. And relating to that, a question has been asked: what are your thoughts on the interactions between nutrient deficiencies, actual microbiome imbalances, and Borrelia and Bartonella, as well as the degree to which autoimmunity?
Well, I think you have to look at multiple. Yeah, there are multiple contributors. So like when you look at the formula, we call it the disease triangle, you have your vulnerabilities, be the genetic vulnerabilities, and then you have your environmental triggers. Now, part of your environmental trigger may be infections, but then there's other environmental triggers. So deficient toxins and deficiencies and allergies, they're on that list. So, and what are the deficiencies? And one deficiency is like, if you look at the epidemiology with COVID, like vitamin D deficiency was quite interesting, because why was there a pattern that in northern cities, COVID would kind of back off during the summer and increase in the winter, but in Arizona, it was the opposite. And why was it worse in bigger cities and worse with dark-skinned people? Vitamin D deficiency, think of it from that perspective, that when you're in a northern city in the winter, you're more vitamin D deficient, and that's your cold and flu season, vitamin D deficiency. Dark-skinned people were more susceptible, they were more likely to have vitamin D deficiency. But if you live in Arizona and it's 120 degrees, you're not going out in the summer, you're staying inside. It's so there was a kind of odd opposite pattern that but I think there's other deficiencies too that like zinc or what else makes you more susceptible? And some people have unique deficiency. Now, parts of the microbiome, and your microbiome can work for you or against you. And is there problems with your microbiome that makes you more vulnerable? And that's always the quandary when you think, do I give an antibiotic or not? Am I going to injure the microbiome?
Yes.
And the microbiome comes up a lot with these conditions, comes up a lot sometimes with the studies with autism, although some of these are other infections, some have to do with microbiome.
Yeah,
and the microbiome isn't just in the gut, it's in the whole body. And people think of just the microbiome of the gut and ignore the microbiome in the rest of the body. And that's, I think, what happens, like if you think of, let's say, shingles, chickenpox, it's in your body somewheres. And I think Lyme, once you get it, it may be hard to ever eradicate it. And it may be in your body, it may be suppressed. And then when you get the COVID, now you're no longer suppressed. So I think there's that constant interaction
between the two. Even that's fascinating, as you were explaining previously about the remedies sometimes working for both, but one of them being a bacteria and one of them ostensibly a virus. It's interesting. There is a question here that links to that. Why do a small percentage of Lyme patients have their Lyme symptoms disappear for a short time post-COVID infection? Do you know what the mechanism could be?
Well, the one would be if they had the high fever. Okay.
I remember you mentioned that.
Hyperthermia is a treatment. It's a treatment there in Europe and Germany. And they're using hyperthermia treatment for depression and cancer. And there's three, like, different degrees, like there's extremely high, but moderate is safer. Now, but the other thing may be the treatments that they got for COVID might have helped the Lyme. What treatment did they receive?
There's a comment here, because Lyme is immune suppressive, but of course there are arguments that Borrelia is also immune suppressive, isn't it?
Yes.
Yeah.
Well, I think of it like, here's the way I like to think of it. I think of it like a fox hunt.
Mm-hmm.
You have three different species. You have horses, people, and dogs. When those three interact, it's more dangerous to the fox than if you only have one of those three.
Mm-hmm.
So it's not 1 + 1 + 1. You have a multiplying effect. Now, I think AIDS is a good example of that. And you see a complex interactive infection. And I think you have to think that way with Lyme, with COVID, with a lot of these things. And we don't fully know all these interactions that occur. They're beyond we have to have humility. They're beyond our ability to understand. And for instance, you see Epstein-Barr a lot, and Epstein-Barr comes up complicating a lot of things. It comes up
Absolutely.
a lot with MS.
Yeah.
But when you see Epstein-Barr plus Lyme, that's a bad combo.
Mm-hmm.
So it may be, someone had Lyme and they got it 20 years ago and their body kept it in check. And now they have an auto accident and boom, it gets activated. Mm-hmm. Or they maybe had Epstein-Barr, or they may had something else that's a triggering thing. And that then pushed them over the edge that caused disease progression.
Yeah, one of the questions here is whether you're seeing aspergillosis or fungal infections as being a driving force with more infections now than in the past. Are you seeing?
Well, there are some of that with psychiatric illness. That was on our list.
Okay.
And although it didn't come up as high as some other things, candidiasis and other fungal infections.
Mm-hmm.
And it's that's an environmental thing with some people, histoplasmosis or other there's geographical patterns with that.
Right.
But sometimes you see that when someone's immunocompromised,
mm-hmm.
then they're an opportunistic infection that pops up when you're immunocompromised, and it's part of that complex. I like the phrase complex interactive infection.
That's, very, very good term. One question here is, I think it links to something you said previously. Are you saying that trauma, like an accident, can trigger a relapse of Lyme even?
Yes. Yeah. Like you may see where someone had it and maybe their body kept it in check. And now when they're traumatized and the trauma maybe makes them immunocompromised. Think of it like this. Your brain is an allocation of resources device. And there's stress syndrome and sickness syndrome. So if I'm in a war zone, I'm more in stress syndrome, where I'm focused on environmental risk. My greatest danger is what's in my physical environment. Whereas if, let's say, I came down with an infection yesterday and I go home and I have sickness syndrome, I just curl up in a ball, I'm lethargic, I just want to lay around and do nothing. That's sickness syndrome. And in many ways, that helps me recover. Now, the problem is when you have both at the same time. So if I have chronic illness, I can have sickness syndrome, but stress syndrome, trying to keep up with everything. And when you try to fight a battle on two fronts at once, you're not going to do a good job. Something's going to give. So that makes it hard to ever recover a lot of times. So I've seen that a lot where now I had a paper that I did where I looked at post-traumatic stress and immune encephalopathies and adverse childhood events. And I looked at those three things. Now it's interesting how trauma and autoimmune disease are very similar. And here's what I mean. Well, immune disease is like, ideally, let's say I get exposed to some bug, and then I get early inflammation and an adaptive immunity, and now I'm fine, okay? But when it's pathological, rather than getting early inflammation and adaptive immunity, I get persistent inflammation and a lack of adaptive immunity, and maybe autoimmunity. So the immune system keeps being provoked, but it's fighting in the wrong way, right? Now that's similar to post-traumatic stress, where post-traumatic stress, I'm sensitized to some environmental danger, and I keep reacting to the wrong thing, and I don't have adequate discretion. So in both cases, I'm wasting a lot of energy fighting the wrong thing. And if you have much in a way, particularly adverse childhood events, you have compromised immune functioning. And if you have compromised immune functioning, it makes you more susceptible to post-traumatic stress. So the two kind of, one is a failure, they're both a failure to adequately discriminate danger and properly react to danger and not react to the wrong thing, whether it's internal danger, which is more the immune system, or external danger, which is more post-traumatic stress.
That makes a lot of sense. Thank you. A lot of different participants are asking whether we could post a link to your microbes and mental illness list. Is that something that we could do now, or should we send it out later?
Well, that's I'm going to publish it, but it's taken forever. It's being reviewed to death. Okay, it's been in review and it's back and forth. The problem is right now it's like 50 some pages long and 450 references.
Oh,
So
wow.
now I will discuss some of these things when I give my talk in Dublin at the crypto conference on the 18th of June.
Yeah.
And in that, I'll share some of my findings of the list of some of the microbes we're talking about.
Oh, thank you.
So,
sorry,
that will be public then. Okay.
Brilliant. No, that we're looking forward to that. When they talk about list, I think they mean the forum that you mentioned earlier with the many hundreds of doctors and therapists.
Well, that's for doctors. That's for doctors or psychiatrists or psychologists. Okay. That's not a public list. Okay. Yep. So that's the purpose of that was to educate psychiatrists. And we kind of met together and we said, gee, we're all seeing the same thing. Let's share what we find and kind of improve. So that's for doctors to kind of, we're always trying to educate more doctors and we're doing all these educational programs. But as soon as we educate more doctors, then they get overwhelmed and there's not enough doctors.
Yeah, yeah. Another question here. I'm not sure if you'll feel that you want to answer it. If not, just tell us. I assume we're talking about COVID infection and the vaccine reactivating Lyme. If there is vax injury, do you also have to treat the injury and not just Lyme and Co?
Well, I think the vaccine may activate with some people too. Okay. It's, you know, it wasn't the best vaccine in the world. And I think different vaccines had different effects on different people. And I think there were issues with different lots of the vaccine, even the same vaccine.
Yeah.
And, you know, one issue was the clotting. That was a separate thing, but it did seem like there was some myopathy that some people did get, and there was underreporting. And I've seen it cause some significant issues. I saw that with the Lyme vaccine.
Oh, right. Yeah.
Years ago, that had quite a bit of problems.
Yeah. I think talk has come up again about reactivating that, hasn't it? Is that something you would suggest should not continue?
Well, here's the problem. They picked the 31 band on they also used the 34 band, but they never did much with it. But the 31 band in the Western blot, that was really, that caused a lot of autoimmune disease and neuropsychiatric illness. And so there was a person in the trial that committed suicide, and there were a lot of and that's in the transcript of the proceedings with the FDA. And there were a lot of side effects. They didn't just take it off because of lack of sales, but there was a reason why there was lack of sales, because there were adverse reactions to it. Now here's a problem with any Lyme vaccine. Since you don't get adaptive immunity to Lyme disease, you can get it 100 times. How can any vaccine work? Okay. So now the best vaccine, I think, is the one that's tick saliva vaccine. Because when you get a tick bite, you get all kinds of stuff that who knows what's in it. And even if you do succeed at having a vaccine against Borrelia burgdorferi, sensu lato, sensu stricto, so what? That's not all you're going to get.
It won't cover all the different strains, exactly.
Yeah, but if you have a vaccine against tick saliva, then it could prevent the tick bite and whatever that tick might be carrying. And that would be a far better vaccine, and that is one that they're working on. So I really question, and this is like a little variant of the 31 band, and is that a variant enough or not? I don't know, but and even if it does, it wasn't that effective anyway, and it took a lot of boosters. So I'm not sure. There is a bias on the part of public health to use social distancing and vaccines and ignore chronic illness.
Yeah.
Okay. They did it with Lyme, and although they're better, you know, with the COVID of recognizing chronic illness than they were with the Lyme, but there's that bias, and not to use other treatments, not to use antimicrobial treatments. That's their bias. Sometimes it's a medical legal consideration where you're better protected with a vaccine than with other treatments. Medical
legal, yes. I think this links to the third topic that you mentioned at the beginning you'd like to briefly cover, which is, has the COVID epidemic changed how Lyme disease is viewed, would you say?
I think it's also brought out, you know, it's made people more aware of the failures of our healthcare policy process and leaders and bureaucracies, that they're quite deficient. And you really get a lot of misinformation. So there's misinformation with Lyme, and there's misinformation with COVID. And at different news sources have a bias one way or the other. So you really have to filter through a lot. You just can't take something that certain organizations that we think would be respectable or as factual without bias. And now I think it's also made us more aware that there's these chronic immune inflammatory conditions that exist and it persists. It was interesting that, you know, do you realize how long it's been that I've been trying to get a psychiatric unit where we could hospitalize people with neuropsych Lyme, and nobody wants to do it because you can't get money for it. Nobody will pay for it. Okay. Everybody says we need it, but nobody wants to pay for it. Insurance companies don't want to pay for it. But all this money came forward with COVID, like post-COVID clinics.
Funds have appeared suddenly. Yeah.
Yeah. Now it was nice that money came forward, but how come it never came forward with chronic Lyme clinics?
Exactly.
Right?
Yeah.
And part of it, there's less denial, but it's still, and even these clinics, I'm not sure how much they do. Like there was a recent thing coming out, it was just in the news today about exercise, and that's nonsense.
Yeah.
And exercise, we've been down that road with chronic fatigue.
Of course. Yeah.
And we know that that doesn't work, all right? And it's not like you can condition yourself back to health. It makes it worse. So some of these things are a waste of money, and some of these research projects, I think there's a huge amount of money they're putting into researching that facet of it, which is an obvious, why would you waste money with that? But
yeah,
an awful lot of money and research wasted in the wrong thing.
Yeah, comments are being made here. All the COVID money has been wasted, zero benefit to long COVID patients.
Yeah.
One question here, which I'm sure you've encountered, why is inflammation and sensitivity to meds worse after COVID? Regular doctors are saying that this particular sufferer is crazy when she says that.
Well, put it this way, it's crazy means the doctor doesn't understand.
Oh, that's true.
And he's too lazy, he or she is too lazy to try to sit down and figure it out, okay? Yeah. So, I see it all the time. Now, sometimes I do see where someone has a normal tolerance to meds, then they get Lyme or COVID or one of these other chronic illnesses, and then they're very drug sensitive and alcohol sensitive too, okay? Yeah. And then when they get better, then they have a normal sensitivity again, right? Now, one possibility, but I don't think it explains it all, is a lot of these people have a general endocrine shutdown, including kind of like a limited thyroid functioning, and I have a low body temperature. So the body temperature might be 97. When you have that lower body temperature, you metabolize things much slower. Think of chemistry 101. Chemical reactions are temperature dependent. Yeah. So when you lower particularly the body, 1 degree in the body can make a big difference in metabolism of drugs. So a lot of Lyme patients, I have to take the lowest dose and start on a fraction of the lowest dose. Mm-hmm. So it's easy to overdose. And I see that with some other people with chronic illnesses. Now, it may not necessarily only be that thyroid. There may be some other piece to it, but I see it again and again. I see it so many times. I've seen it hundreds of times, if not 1,000. Mm-hmm. Are all these people lying? Or is it people just can't figure it out? I think it's an observation that's obvious, that's there.
It makes a lot of sense that because enzymes are so temperature dependent that the reactions are just not taking place anymore.
And they become chemically sensitive. They have a difficulty walking down the soap aisle in the supermarket that they didn't have before. They become more mold sensitive. They become more sensitive to a lot of things. So I think that's a part of these illnesses are very complicated, and you can't look at them with a simple model. If you try to look at them in a simple model, then you say it's crazy because you don't understand it.
Yeah. There are a couple of interesting comments here on virophages. Would you acknowledge that there is an impact of virophages in Lyme and a correlation between Lyme and COVID? And following on from that, there was another comment, I'll try and find it, that the chronic immune persistence are virophages, and COVID is the airborne version of Lyme. It's interesting. It's not something.
Okay, all right. Well, virophage, that's something I was talking with Al McDonald about that. And he's always on the leading edge of things, and he was very enthusiastic. Now, there's two things with virophage. One is you can use them as a treatment if you get a virophage that attacks the Borrelia or whatever microbe you're trying to attack. And it would be quite specific. So it's a great antibiotic treatment. You use virophages, and they're not going to throw off your gut flora. Mm-hmm. So it's useful as a treatment, but it's also useful in a diagnostic way because virophages are very specific. So if you have a virophage, that's rather specific to Borrelia, it's diagnostic that Borrelia are present. So sometimes diagnosing the virophage opens up a new way to make a diagnosis of the presence or absence of Lyme or Borrelia or something that's hard to detect. So your problem in a lot of our testing is most people rely on immune-based testing for an infection that suppresses the immune system. That makes no sense at all, okay? It's so, but that's what the CDC, that's what, you know, and interesting with COVID, and it overlaps with COVID, the CDC says, we don't trust immune-based testing. Only PCR or direct antigen testing, direct testing, but we don't trust immune-based testing for it. Okay, then why do you trust it for Lyme disease? Duh, okay? It's the same issue. And we know that's, although we don't have as many commercially available tests, but in reality, the PCR or antigen testing, that's far more reliable with anything. That's when someone's convicted of murder and you get PCR evidence, it's absolute proof. Why do we deny it with something like Lyme disease? But I think bacteriophages or viral phages that, you know, infect bacteria, I think are a great future. I think that has potential.
Yeah, well, need to keep an eye on that. Another interesting question here was wondering whether the vagus nerve can harbor Borrelia. And would you be able to talk a little about the connection between Lyme and the vagus nerve?
Well, I think it's very interesting in that we know Lyme can have an impact on all cranial nerves. So when I do an assessment, I look at all 12 cranial nerves. Now there's an inordinate tension to the 7th nerve with Bell's palsy, but I don't think the 7th nerve is as frequent. Let's say even the 8th nerve. I see a lot more with the 8th nerve, but the 10th nerve, the vagus nerve, I think there's a lot there. And you see the dysautonomia. I think one part of that and the POTS. So the vagus nerve is very complicated. What it does when someone has babesia and they have air hunger, that's the phrenic nerve division of the vagus nerve. And the air hunger is difficulty extending the diaphragm. So when you want to take a deep breath, let's say you're an opera singer, you have to expand your chest and your diaphragm. It's hard to extend your diaphragm if you have some pathology of the vagus nerve. So, you know, what can we do about that? You know, certainly any antimicrobial treatment or whatever treatment might work, but would vagus nerve stimulators help? Or how do you impact the vagus nerve? But I think that's a very productive area of future research, is looking at that with the dysautonomia symptoms that are a big part of these complex illnesses.
Yeah, there is a lot of research being done in that field now as well. There are several questions relating to EBV and Lyme. Often, of course, patients have both, and as you've said, EBV can readily reactivate. This question is, in your experience, what is better to treat first, Epstein-Barr virus or Lyme, when the EBV levels are always high?
I guess it depends on what's easier to treat. Now, a lot of times you'll see where if you, let's say you test someone and you were to do viral testing, they may show titers from old infection that are rather low. Then someone gets Lyme and you see increased viral titers. Very different viruses. Now, some of the antivirals work against certain viral, but not others, okay? So it's like, so then, and that's part of that complex interaction. But then if you successfully treat the Lyme, you see the viral titers drop. So I think a lot of times they're opportunistic. And I guess the question is, which is easier to treat? Yeah. If you do happen to have a virus that's significant that you can actually treat, then that may be the way to treat it. Or what's easier to treat, that or the bacteria in that complex interaction? Now that's psychiatry, not so much infectious disease, but that's an area more that infectious disease doctors, that would be a good question for Dr. 𝐃𝐈𝐒𝐄 to answer.
Yes, there are a lot of questions here.
But I think that's basically the logic is when you have that complex interactive infection, what's the better starting point?
Yep. Exactly as you mentioned earlier. There are quite a few questions here relating specifically to Lyme, or very detailed questions giving particular titers and asking whether they're very high or not. And we will save all the questions and ask those that are relevant for next time, because we're going to be so lucky to have both of you on again. Another one perhaps relating to CV19 as well as Lyme. Are you aware of any impact of Lyme on vascular symptoms such as bulging or popping veins? Or is this more likely to be COVID or even the vaccine?
Well, you don't have the clotting issue. Sometimes you get vasculitis, although I wonder, is that Lyme or Bartonella?
Yeah.
But and Bartonella, you can get the angiomas form.
Okay. True.
I don't think it doesn't come up as much with veins, although I think we find it in, I wonder with aneurysms.
Mhm.
Is Lyme getting aneurysms? And does that contribute to the weakness of the vascular wall? That happens with syphilis,
Oh,
right?
yeah.
Syphilis, as I recall, can give aneurysms, particularly of the ascending aorta.
Mhm.
But it's now some of these effects are long that occur over time, like Lyme getting into the disc.
Absolutely.
And it erodes the disc, and then years later you get a bulging herniated disc. How did he get it? Okay.
Mhm.
And every now and then someone will take a disc and study, and they find Lyme in a disc.
Mhm.
And that's post-treatment Lyme. So obviously they weren't adequately treated, otherwise the Lyme wouldn't be in a disc in the first place.
Yeah.
So I think, can it happen in the vascular? But veins I don't think of as much.
Okay.
Although you do see, is that part of what's happening with the syncope that some people get with the vasovagal? Maybe that's a part of it, but that may instead be more autonomic.
But perhaps relating to that as the last question, because we're very conscious of your time and know you're there at your clinic needing to get back to patients. I saw an interesting question here that's just disappeared. Yes, is vertigo due to the presence of Borrelia in the vagal nerve, or can it be?
I think it's more the 8th nerve usually. Okay. Now, what happens, like a lot of times, one way, like the vertigo, a lot of times the person, when they close their eyes and try to sleep at night, then the vertigo gets worse.
Mhm.
So, but if you have vertigo, you may have other 8th cranial nerve symptoms.
Mhm.
You may have tinnitus.
Mhm.
You may have mal de déembarqué, where you feel like you're on a boat, but you're not on a boat. You may have sensory processing problems, although some of that's more brain rather than actual 8th nerve.
Mhm.
You may have hearing loss. You may have sensitivity to high pitch or low pitch. I've had patients that a high pitch voice they had trouble with, or low pitch. It depends on what part of the cochlea there may be injury.
Oh my goodness. Yeah.
And so those are 8th nerve problems. And that goes, I had a patient the other day, and they said, well, if they turn their head to the right, that would give them vertigo.
Mhm.
And that made sense, because the cochlea has 3 different loops on 3 different planes. And it helps your orientation in space.
Oh, wow.
So that maybe going like this you're okay with, but going like this they would have trouble with.
Fascinating.
That's obviously 8th nerve, cochlea. That's a problem that you have with, but I think of that as not so much the vagus nerve.
Mm-hmm. Well, thank you so much. There are so many questions still pouring in. We'll save all of them and hopefully be able to answer further questions when we have you and Dr. 𝐃𝐈𝐒𝐄 the next time. Thank you very, very much. It was
Okay,
amazing.
all right, pleasure, Joanne. Okay.
Your answers were superb. I'll just mention that on the 31st of May, so that's just in 1 week, we'll have Dr. Armin Schwarzbach talking about Lyme and related symptoms, including COVID-19. And that is going to be the last in our series during Lyme Awareness Month. So we very much hope to see you then. That's a Wednesday. And this will be recorded. Several people have asked. The recording will be, well, it has been recorded. The recording will be put up on our website, and we will, of course, send it to you, Professor Bransfield, as well. And we'll be listening to you at the crypto conference as well.
Okay, and I see a question about tinnitus. Yes, tinnitus is commonly seen with Lyme disease. Okay, and sometimes Campbell works. Not with everybody, but a few people. It's a drug for alcoholism. And there were 2 studies in Europe, I think one in Spain and one in Italy, that showed some effect with a few people. And that can drive people up the wall. It drove one person to suicide who had a big restaurant chain in America. So that's an 8th problem.
Yes, thank you. Fantastic.
Okay.
Tip there. They're asking for the link to your talk in Dublin. So
well, go crypto conference, and it's in, yeah, they call it the crypto conference.
Yeah, we'll send out the link together with your talk when we send out the.
Yeah, I'm not sure how they're going to do it, and it's with Invisible International is involved with that, and I'm not sure if they'll record it or, but I'll be talking on the 2nd day, and it's, yeah, if they could join us in Dublin. Okay,
every Saturday and Sunday, but it's also virtual.
It is? Okay, good. Okay.
I've seen that because I'll be joining virtually. I'm in Dublin next week at TikTok.
Oh, good, good.
It's actually this weekend. Yeah.
All right. Okay.
Okay. Well, thank you so much
All
again.
right. Thank you. Okay. Bye.
And thank you everybody for being here, and see you again.
Bye.
Bye.
Bye.